So the confirmatory test will be what we call hydrophonium test or the tensilon test. So basically hydrophonium is a short-acting anticholinesterase, and it will prevent the breakdown of acetylcholine. So anticholinesterase, cholinesterase is going to cause the breakdown. So we are supplying the area with anticholinesterase. So this will prevent breakdown of acetylcholine. And we administer this acetylcholine in 2 parts. Initially, we give an intravenous dose of 0.2 ml and watch for any improvement. If there is no improvement, then we go on to inject the remaining 0.8 ml and look for the any improvement in ptosis. And this effect will usually last only for 5 minutes. So this is an important point. We have to be beside the patient during those 5 minutes, because after 5 minutes, the effect of the drug will disappear and we may not be able to actually detect an improvement. The problem with the hydrophonium test is there are a lot of side effects, which we can to an extent circumvent using atropine, about 0.3 milligram. So atropine will try to overcome this cholinergic crisis. When the side effects, like I mentioned, there can be an increased muscarinic activity and a cholinergic crisis. So to prevent that, we can give atropine, which is an anticholinergic agent. And one of the serious adverse effects of can be, some patients can even develop bradycardia because of the cholinergic crisis. So we should always keep atropine ready. In fact, we start the test by giving atropine to prevent the cholinergic crisis. So the other test can be neostigmine test. Neostigmine test is also an anticholinesterase, but it is a long-acting acetyl anticholinesterase. So it will actually, the duration of the drug lasts longer. So we can actually read the test even up to half an hour or 40 minutes after administering the drug. It is given as an intramuscular dose as against hydrophonium, which is given as an intravenous dose. Then you have, this is actually anticholinesterase, okay, anticholinesterase, which has a longer duration. The important thing is it has a longer duration of action. So it is very useful in children. And the next is sleep test. Sleep test will function by decreasing the fatigue in the patient, and you can observe a little bit of improvement in the ptosis. Another very important and specific test is anti-acetylcholine receptor antibodies and anti-muscle specific kinase antibodies. Now, of these two, anti-acetylcholine receptor antibodies is widely used in the diagnosis of myasthenia gravis, because in systemic myasthenia gravis, up to 85% show sensitivity, and in ocular myasthenia gravis, up to about 70 to 80% will show improvement on ptosis. So it is useful for both systemic and ocular myasthenia, although the sensitivity is slightly increased in patients with systemic myasthenia. Anti-muscle specific kinase antibodies is more specific for systemic myasthenia, but we do employ the first test quite commonly to confirm the diagnosis. Now, EMG, electromyography, is also one of the very important things that we do. We do what we call single fiber electromyography, which will show a decremental response. Okay, this decremental response is again diagnostic of myasthenia, and you can also do repetitive nerve stimulation studies. And CT chest is done for patients to detect thymic hyperplasia or thymoma, which is present in up to 10% of patients in association with myasthenia gravis. So all these tests are very important, because you have to do these tests whenever you suspect ptosis that could have a etiology of myasthenia gravis. Now, the second cause of myogenic ptosis is called myotonic dystrophy, where there is a delayed muscle relaxation. By definition, myotonic dystrophy is a delayed muscle relaxation after cessation of voluntary effort, and it is an autosomal dominant condition. Even after the patient actually stops shaking hands, there is this effort, voluntary effort, it does not stop. There is a continuous absence, there will be an absence of relaxation. And usually it occurs in the 3rd to 6th decades, whereas myasthenia gravis will occur in the 3rd decades in the younger age group. These patients with myotonic dystrophy can have muscle wasting. They have again these mournful facial expression, because the muscles in the face have also are not able to relax. They are in a contracted state. They can have what you call frontal balding. They can have low IQ and hypogonadism. But what is important from the perspective of the eye is this typical Christmas tree cataract is called. So this Christmas tree cataract is one of the common features that is observed in patients with myotonia dystrophy. Apart from that, you can have a light near dissociation of the pupil. You can have pigmentary retinopathy, optic atrophy, and a gradual ptosis. Electromyography will show a decrease in myopathic and myotonic potentials, and there can be an elevation of creatinine kinase.